All right, good morning, everybody. Thanks for joining us. It is my pleasure today to welcome a friend and colleague, Dr. Marat Fudim from Duke. Before we move on, thank our sponsors today, Novartis and Zoll, and encourage you to visit with them out in the foyer. So Marat is someone, I don't know how long we've known each other, but not as long as he's known Nick Hagelin because they spent some time together at Vanderbilt. He is currently an associate professor and heart failure cardiologist at Duke, completed medical school in Germany, residency at Vanderbilt with the world famous Dr. Nick Hagelin, and cardiology fellowship at Duke. He's currently the medical director for Heart Failure Research Unit and Heart Failure Remote Monitoring at Duke, and is a winner of the 2021 American College of Cardiology Doug Zipes Distinguished Young Investigator Award. His research interest is in the pathophysiology of heart failure and heart failure with preserved ejection fraction specifically, and he's going to talk to us about congestion management today. So we're very excited to have you here and eager to learn.
Thank you so much. Thank you. First of all, thanks for having me. I forgot who decided which title of the talk we're going to have, but this is the one I was given, and I said yesterday over the weekend I was preparing this talk, and I intentionally, my disclosures, wanted to not bore you. So we're going to make this a little bit untraditional. I'll make this a little bit different than my usual talks maybe, but we'll be hitting on three specific topics that I do a lot of research on, and we will try to challenge existing concepts rather than just belabor how you decongest somebody. Trust me, I know that you know better than me how to decongest patients, and I will try to open your mind to novel concepts to talk about some of the concepts surrounding the management of congestion might be unusual. This is a recent publication that really indicates that we have a big problem in our hands. So heart failure is the electrophysiologists say AFib is king. I say, no, heart failure is king because heart failure is the #1 cause for hospitalization in the United States. It's the #1 cost item in CMS. The incidence of mortality, the y-axis is incidence of mortality. For every 100,000 patients in the United States, how many patients die of heart failure per for CDC Wonder, that's our FDA database, government database. And the incidence has been going down over the preceding -20 to -10 years, but in the last 10 years has been going up to actually surpassed the levels of 1990s. So despite the advance of GDMT, ICDs, or whatever else we brought to our patients, we actually have failed to improve outcomes in our patients. This is a little bit specific to the United States. I tried to replicate that in Europe after we published this data, and it doesn't look as bad, or it doesn't look like that at all. And we can't blame it on COVID because COVID only contributed to the last 2 years spike. We can't blame it only on coding, but I think it's really the result of the metabolic health crisis, obesity. And if you look at the things that particularly affect is the urbans, if you're urban as opposed to rural, if you're rural here in blue, your chance of having a heart failure-related mortality was just 30% worse. And the worst outcome that we didn't anticipate is that patients below the age of 45 are the ones that actually are carrying the brunt of that increase. So if you look at your patient population, it's funny, I have a Polish professor rounding with me on a Fulbright scholarship, and the first thing he said after rounding me on the general heart failure service is like, I did not expect to see so many young people in your service. They don't have that in Poland. They're 70, 80 years old, and we had a decent amount of 40s and 30-year-olds in my service. Okay, so I would say that the particularly biggest unmet need is, of course, in heart failure preserved ejection fraction. Why 70% of heart failures have PEF with an ejection fraction of, let's say, 50 and greater. We have failed to deliver many positive results. Many of the trials that have applied the HFrEF therapies to HFpEF have not panned out. And interestingly, in the majority of therapies that worked in heart failure preserved ejection fraction are therapies that were not cardiocentric. They were not even targeting the chest cavity. If you think of weight loss strategies, SGLTs don't even have receptors anywhere in the chest or of the vasculature. So therapies in HFpEF don't seem to be conducive to focusing on the heart or the vascular system itself, but you have to think a little bit out of the box. So how do we typically assess congestion? Don't have to tell you that. There's many, many ways how we assess congestion, but at the end of the day, we assess congestion using physical exam. As a matter of fact, you at this institution, because you use a lot of blood volume analysis, a little bit further along the curve, which is one way to diversify how you assess congestion. We as physicians or APPs are notoriously bad actually translating our physical exam findings into what the intracardiac pressures would be. as a push for maybe considering to do more radical catheterization. But then, so assessment over the last 30, 40 years has not changed at all in heart failure. Has the treatment changed in heart failure for congestion? And again, this 2 slides summarize what the title of the talk should have been. Is that actually hasn't. This is a European guidelines from a couple of years ago that I was able to contribute to. The guidelines today tell us to use diuretics, vasodilators. All of that is just circumstantial evidence. And the only new innovation that we had come through in the last years is to consider using spot sodium urine. We don't do this very often in the United States. We do it a lot more in Europe. You guys use urine spot sodium to guide your diuresis?
We're starting.
Okay. So that is coming to the mix. Everything else, diuretics, doesn't matter if they're bolus, continuous, it doesn't matter if you use high dose, low dose. I mean, we have actually no evidence to suggest one strategy is better than another. Some trials came through, such as the ADWARD trial with acetazolamide, but these are small, inconsequential trials because all they did is shorten length of stay maybe by a day. So the reality, however, is that decongestion is likely not only a product of volume removal. And I think we need to move away from thinking of ourselves as volume removal doctors, because this is data comparing the ADHERE trial, which is now 20 years old, or ADHERE registry, 20 years old, to the TREAT-HF registry. It's like 149,000 patients across the United States where we pulled healthcare records from them. This is how much you lose in weight throughout the hospitalization course. And the 2 colors indicate the 2 different registries, indicating that whether it was 20 years ago or last year, it didn't matter. The trends remain the same. And what you see is that 20% of patients throughout the hospital stay admitted for acute heart failure and coded as such, had actually 20% of them had weight gain. So they come throughout the hospital stay, we love to diurese, that's what we do as number 1, number 2, number 3 action, but 20% of them had weight gain, and an additional 28% actually had, if at all, only 0 to 5 pounds weight loss. So if you do the math, about 50% of patients leave the hospital and had inconsequential weight loss or had weight gain. So clearly, weight removal or diuresis is not what was done in these patients or not what they needed. So now, congestion diagnostics in the hospital and outside of the hospital has now evolved. Of course, I sort of indicated that physical exam has been there for 50, 60 years and hasn't really changed. But now with technology, and some of the technology is actually out there with Zoll Medical, has transitioned to where we monitor patients with invasive, non-invasive tools. That has evolved, but I would argue the biggest barrier to doing any more diagnostics on congestion is that it's about the data and what do we do with the data. And I'll speak to that a little bit later, but the problem really lies to the right side of it is that that lady that has to process the data and the amount of data coming in, people just don't know what to do with it. So we often don't rely on congestion management tools and abandon that thought, even though a majority of patients will probably benefit. So another intro slide would be to say that because decongestion has so far, not improved outcomes, I just showed you outcomes, if at all, are worse in the United States. We don't remove that much fluid. It might not be necessarily about volume removal. We might have to be innovative on our decongestive approaches beyond diuretics, because all our trials at all today are diuretic plus diuretic, diuretics minus diuretic. I mean, that's the only thing we're testing, and the outcomes are all neutral. And it might require unconventional thinking. So I'm going to give you some of those unconventional thinkings here in the next few slides. And obviously, you can target many, many different things. There might be vasculature and extravasculature in order to improve our decongestive approaches. So the first concept I'll drill down on is pressures do not equal volume. I'll hand out later shirts that say that for you all, okay? See if you follow. All right, so the paradigm was, for me, I was actually at Vanderbilt when this paradigm, for me, was born, and we created the concept around this. I was a resident. Nick was the attending. Yeah. Yeah, I don't know. I think you were the attending. But by the way, he never ages, which is amazing, because he wasn't attending for like 15 years, and I still looks the same. But what I realized is that we had patients that came into the hospital that in average had no weight gain. The average patient admitted at Vanderbilt at that time point when I did my homework had plus minus 0 pound weight gain. It is actually substantiated by data. If you look at historical data of patients prior to hospitalization with remote scales, which are studied as such, and they go into the hospital, the average weight gain is 0 pounds. But the intracardiac pressures, if you would have put a CardioMEMS or like devices into them, the pressures always go up prior to a hospitalization event. The biggest truth out there is that pressures have to go up in order for you to be called congestion. That's one truth, but it does not have to come at the cost of volume gain. So weight gain was neither necessary nor sufficient to explain cardiac decompensation. And then comes this data from Cleland and colleagues in Scotland, which I think is one of my favorite trials. They took 20 patients with HFrEF, they put them into an early phase unit, took all the diuretics and GDMT away, which was available back then in 2017. And what happened to those patients that were hospitalized and confined for 48 hours, where they monitored how much they ate and drank and measured the output? Symptoms worsened by 1 NIH point. NT-proBNP doubled. Blood pressure increased. They measured how much water was on the chest using impedance technology. That increased. There was more water on the chest. And the LA size increased. I mean, classical iatrogenically induced decompensation. You took diuretics away and GDMT. That's what happens. But that did occur without weight gain. So you did not need weight gain in this patient that clearly has a classical decompensation to explain that they were getting worse. So if we want to talk about volume and what's contribution to heart failure, let's talk about where volume is distributed in the human body. Turns out the majority of blood sits in the venous system because it's stretchier, it's more compliant. The majority of venous blood sits actually in the abdominal cavity. Why? Because the abdominal cavity is very rich in organs that are pure sponges for blood. Liver, spleen, the gut. It's pure venous beds. There's actually not much of the arterial tissue there. If you do the math, 40% of total intravascular blood volume sits in your abdominal cavity, specifically in the venous pooling of the abdominal cavity. So now, whether you believe in Mother Nature or God, and I don't know what you guys believe here in Minnesota, I know what we believe in North Carolina, but I'm not a believer. But there are 20 times more nerve endings on the vasculature of the abdominal cavity than on the vasculature of the arms and legs. So the Creator wanted you to have more tight control over the vascular tone of the abdominal cavity. Why? And that's because the majority of blood sits in the abdominal cavity. So it wanted to have tight control. Small changes in the vascular tone results in large shift of blood volume into the chest or out of the chest. And that really then led to the concept, well, that's really because then shifts of volume might induce pressure elevations rather than volume gain. So that's the concept of volume distribution. It's not that novel. We have thought about it for decades. And then maybe that is the process we should be targeting in order to prevent decompensation. So I'm going to make this simple. This is a cheap bottle trick because I can't afford more than this bottle as a demonstration tool. I don't have fancy draftsmen. But the idea is that this bottle is capped. You cannot add water to it right now. Anything above the yellow line is CVP. I can increase the CVP by increasing vascular tone peripherally. So I vasoconstrict. That thumb is actually sympathetic tone. And that is referred to as the stress and unstressed blood volume concept. So the shift of blood from the below the bottle, which is the reservoir stores of, for example, the Splanchnic compartment, you can recruit from them 500 cc's within minutes, if not seconds. In animals and in humans have been demonstrated, and shift the blood. So you don't have to add volume to decompensate. You just have to shift it from the periphery. And it can be over the course of minutes, weeks, maybe even months. And that's the process of decompensation. To make it even simpler, Jean-Claude Van Damme has done the same thing by, that's the visual representation of what the sympathetic tone does to you. In the manner of, to not get in trouble with my Duke people, I, of course, cited it properly in the bottom. I had to look back. So now I'm gonna set this up because blood volume is something you do actually a lot more frequently than we do in our institution. The concept is you inject a radio tracer, because I'll have to set up my next experiment. You inject a radio tracer and you can actually measure how much blood is there in the intravascular space. So this figure is actually something I've been quite proud of because we took 2 centers and we implanted CardioMEMS into them. Why? Well, because we have, like you guys, a lot of patients struggle with congestion management, fluid management, post-discharge. But before we let them go, we also gave them blood volume analysis right there on the table. So I'm going to explain this. On the y-axis, we measure blood volume deviation from ideal. You want to be in the green zone. You want to be around plus minus 10 of your age, gender, height predicted blood volume in the vasculature. If you're up here, you're wet. If you're down here, you're dry. This is just the right zone. And then on the x-axis is PADs, PA diastolic pressure. So PA diastolic pressure equals wedge. You want to be in the green zone. You want to be less than 15, let's say. The majority of patients I would have expected in the yellow zone, high pressures and high volume, but it was not the case. The majority of patients were in a blue box, high pressures, but low or normal volumes. Again, the majority of patients running around across 2 centers was Tennessee and Duke. that had high pressures. That's a typical patient with a cardiomyopathy in place, but the volume was normal, or sometimes even low. So the idea that your patient with wedge pressure of 30 is automatically volume overloaded is simply not correct. And by the way, that is not a new figure. That figure is only new because we did it in the setting of a cardiomyopathy. And figures like this have been presented already in the 80s. The problem with this is that when we give somebody a cardiomyopathy, we automatically, for the rest of their life, will associate high pressures with higher volumes, and we'll do what? We give them diuretics, and again diuretics, and they get frustrated that diuretic increase does not change the outcome. So pressures do not equal volume, not a novel concept, but I'm going to demonstrate to you when clinical practice actually came to fruition. So this is an analysis, and Peter will be familiar with this, from a community hospital in Jersey. They took all comers as a standardized protocol, and on admission to the floor, when they have heart failure signs and symptoms, they gave them blood volume analysis, and they found that 50% patients had euvolemic or hypovolemic blood volume, but also were anemic at the same time. So the majority of patients are euvolemic or hypovolemic with anemia, and an additional 12% here had at the same time a normal red blood cell volume, but still were euvolemic or hypovolemic. If you do the math, 62% of patients hitting the floor at your hospital have normal blood volume. So that was in a community hospital, okay, where there was one heart failure cardiologist. And when they looked at the outcomes of the patients that were managed using blood volume analysis, longitudinally, because I did blood volume on admission and prior to discharge, they had very, very good outcomes compared to a propensity match score. The only thing is this is a smaller hospital, maybe not as a high acuity care, but they matched it to Medicare data and had a ridiculously good outcomes all the way out to 1 year. A little bit too good to believe, but that was what it was. So I repeated that experiment. I'm going to show you only the single arm data, but we did the same thing and said, well, maybe it's different at Duke. We have big coordinator centers. We have a basketball team. We must be better, right? Okay. It's not Jersey. But what happens is that we actually had very similar data. This is admission blood volume analysis at Duke when they hit the floor within 24 hours of admission. At this time point, they have received, in average, 1 dose of IV Lasix, so they couldn't have been dried out yet. And you would have wanted them to be in the green zone, but we would have expected everybody to be far on the right. You see that about half of the population was either around the euvolemia zone or barely volume overloaded. So again, it shows us a good chunk of patients get presented to the hospital, they have no significant volume gain. But the residents and the fellows and the attendings overnight will give them ED, bless their hearts. I mean, they will give you IV diuretics no matter what before they say hello usually. So another practical example is how we actually manage this data of blood volume and pressure at the same time, which I think gives you two ends of the curve of congestion. I consider congestion to be a multifaceted picture, and two colors to that picture is pressures and volume. And so this is a patient I actually removed out of time constraints, the other cases, but this is a patient, she's a patient of mine, apical HCM, essentially a very stiff HFpEF patient. She had a cardiomyopathy implant, and here in green is what the pressure looks up on implantation. It was 19. The wedge pressure was 19, and she had 40 of Lasix on board. I did a blood volume analysis, and it was minus 14.9 for total blood volume, first row. She was mildly volume deficient and at high pressure, so one of my typical cases. What did I do on her? I actually started to decrease Lasix. I decreased over 2 weeks and weaned her off the Lasix. Well, that sounds counterintuitive to do it in the setting of high pressures, but because I had the volume component to it, I was able to do that with more confidence. And unlike what you would have expected when you withdraw diuretics, no changes in her ACE and ARBs, because the only other drug she had on board, she had a decrease of pressure over the subsequent weeks. I withdrew diuretics, and she had a decrease in pressure. Why would that be? Well, if you give somebody diuretics where they have no business in getting diuretics and you dry them out, what is the body going to say? I'm going to hit you back. The RAS system will get overactivated and actually vasoconstrict. That refers to as compliance. The body will hit back and try to conserve the little blood volume it has left and try to vasoconstrict. So that's a compliance play. So I think I have several cases like that, and we publish them where you withdraw and you actually have a decrease in pressures, which is counterintuitive. So could we target that thumb now that's causing us decompensation and try to prevent the shift of blood rather than the volume overload, which is often not present? So we simulated this thumb phenomenon and see whether it was true. We took patients. This was my crazy experiment that nearly got me fired from Duke right in my first year of fellowship. They did open belly experiments at Duke because, not experiment, they did RFI. So they did high radiofrequency ablation for pancreatic tumors. And they approached me and said, hey, when we ablate these tumors, we see ridiculously high pressure, blood pressure, but the patients are sedated, they have epidural anesthesia. And I said, where are you stimulating? Pancreatic says, like, oh, that's where the celiac plexus sits. Celiac plexus is what innervates the abdominal cavity. It's a common confluence of the nerves called splanchnic nerves. So what we did is we actually line up these patients. They're completely out. They even have no signal to the brain back because they have epidural anesthesia as well. And what we noticed is that if you stimulate splanchnic nerves, which send signals down to the splanchnic cavity, you had doubling of blood pressure, doubling of cardiac output, higher central filling pressures. Within seconds, you turn it on, it goes up. You turn it off, it goes down. It's an on-off within 30 seconds. We went with Vivek Reddy in Mount Sinai, actually repeated an experiment out in Prague, and we now put a catheter down the azygos vein that goes down into the intercostal vein. Why did we do that? Because you get close to the splanchnic nerve. The anatomy is relatively fixed in this relationship, and we didn't have to go and open up any bellies. And what we noticed is that if you stimulate that in a heart failure patient now, the pressures also, there was an increase in RA, LA pressure, because this was patient instrumented for atrial fibrillation, it was direct LA pressure. All the pressures went up, but unlike in the healthy cancer patients that didn't have cardiovascular disease, the pressures did not go up and down, they went up and stayed up. And that told us that once you shift blood centrally into the chest cavity, which is it's restricted, constricted in those patients, that they actually were not able to tolerate the volume shift, and the pressure seemed to be elevated for a while. It's like a vicious cycle kick off. So that's all. Maybe that's one thing we can target now by preventing distribution of blood volume. So one experiment we've done at Duke, supported through internal funds, we actually blocked the nerve with ropivacaine, which lasts 12 hours. So we exercised the patient, here in black, on the supine bike. Pressures went up. We exercised them all the way to peak. This is PA pressure and wedge pressure. This is a typical exam in a HFrEF patients. These were advanced HFrEF patients. And then we blocked the nerve, gave them an hour break, and repeated exercise. And the filling pressures dropped at rest and with exercise. These are heavily sick, congested patients. So they gave us a confidence, maybe there's something to it. And then what we did is we inject another radio tracer in them. It was not iodine, albumin, but we give them technetium-99, a lot more radiation. Put them on a gamma camera for a reason that I have not yet told you or shown you the shift of blood. I just referred to surrogate markers such as pressures. Because with exercise, pressures rise in the chest. That is in large degrees driven by volume shift, not by anything else. And that's very important. How do I know there's large degrees driven by volume shift? Because simply the passive leg lift in PEF or F patients already elevates the filling pressures by around 7 millimeter HE. Just lifting the legs, nothing else happens than volume shift. That lifts the pressures. That's all you need. Then with exercise, you shift even more volume. So that's one of the key mechanisms of what leads to exercise-induced filling pressure elevation. So we wanted to demonstrate that by actually tagging red blood cells. Every black dot is a red blood cell where they concentrate. You can see the outline of central vasculature, liver, spleen, and obviously the heart, which is a fluid-filled organ. And then what happens is now we exercise these patients and we compare the thorax to abdominal ratio in counts. So the more counts are in the thorax compared to the abdomen, that ratio turns positive. There's a shift of blood into the chest. So what happens, look at the black only. We exercise them from rest to exercise. And you see there's a small shift in net distribution of blood from the abdomen to the chest, that the ratio rises. There's just more counts that went to the chest. Then we blocked them with Botox and came 1 month later. No change in medications were allowed. And we noted that at rest, the amount of blood in the chest dropped. And with exercise, there was still a shift because we obviously didn't kill all the nerves, or there were other processes leading to shift of blood. But there was a lesser of a shift or less amount of blood in the chest at the end of the exercise. So that was just one way to just actually mechanistically demonstrate that not only the pressure's lowered, but also less actual red blood cells moved into the chest. Okay, so a couple of experiments followed to say, okay, listen, we now blocked them with lidocaine, we blocked them with ropivacaine, we blocked them with Botox. Let's cut the nerves. Let's make sure we actually get the nerves directly. We've done an experiment out in Poland and the Czech Republic. We actually cut the nerves bilaterally, and it resulted in similar to prior, but now in HFrEF patient in a single-arm experiment to lower filling pressure, see in black, all the way out to 12 months. So again, if you repeat an experiment in an open-label single-arm fashion, there seemed to be benefit on hemodynamics, evidence of functional benefit and quality of life. A dedicated catheter system was developed, and I hope you will be part of the future trials here in the next 6 months. You actually can shift that catheter all the way down to the azygos I showed you earlier. It's relatively easy to do. It's so easy I can do it. You don't need your fancy interventionalist for this. And you place it it's landmark driven because you actually can't see the nerve on X-ray. And what we found, to cut it really short, the overall study, because we did a patient population finding study. We did 90 patients with all comers of FPEF. You just had to have a oral diuretic use that was escalated in the last 12 months, IV diuretic use, or heart failure hospitalization, or NT-proBNP of greater than 125. We essentially took all comers because we didn't know who is a shifter. I cannot look at you all and know who's a shifter unless I have serial pressures and blood volume analysis to maybe get to this mismatch. Pressure does not equal volume. So we enrolled everybody, and we essentially wanted to find these people, like in the bottle, that have an increase in pressures without the addition of blood volume. And what we found is that about half of the population had the ability to respond to denervation. So half the population responded, and response was measured as improvement quality of life, shortness of 6-minute walk distance, lower filling pressures, or lower NT-proBNP. And the people that responded were the ones that were able to augment cardiac output. They were not preload dependent. That term will be coming up again and again. They were able to augment heart rate, so they were not limited by chronotropic insufficiency, which is you treat with pacemakers, don't ablate them, and actually did not have orthostasis when they stood up. So it's very important. If you stand up and you are having orthostatic blood pressure drops, you cannot augment or maintain your blood pressure in a standing position. That's a problem. These people are preload dependent. Do not take away from them blood, because this is the ultimate unloading tool by opening up the splanchnic compartment, dumping blood in the venous system. So those are the criteria. It's a little bit esoteric, but this is what's going to be used for future trials as an exclusion criterion. Patients that do not have the ability to augment cardiac output with standing will be excluded. So this is what it looked like in the responder group. There was somewhat of a lesser improvement in exercise filling pressures compared to the sham. We can talk about why we had such modest results, but this was a sham control group. Anything looks less prominent in a sham control group. When you look at the clinical outcomes in the responder group, it looked actually pretty good compared to the sham control arm. There were clinically significant changes. Still a very small cohort because it's only half of the population that were responders. So it's only 25 patients, 24 patients that actually had met responder criteria. So that was concept one. Pressure does not equal volume. Concept number two will be gravity matters. It's getting increasingly complex as we go down the line. So this one is going to get me a lot of enemies because this is not pretty. I actually have 90%, 80% of my clinic is heart failure, but I'm actually a dysautonomia doctor. I see just POTS, NOH. I make myself a lot of friends because I say, just send me all your trouble patients, because nobody likes to take care of those patients. But I actually like them because I think they're on a continuum of disease. In heart failure, I just told you we have a net distribution of blood volume into the chest. It doesn't actually mean that you have volume overload, but it's the net distribution of blood into the chest. That's the physiology. Heart failure, hypertension, obesity, that's what those disease states do. That's how they elevate your intracardiac filling pressures. Now, the opposite of this is dysautonomia, whether you, through the inability of maintaining vascular tone, are inappropriately pooling blood in the lower extremities. That's why we recommend POTS ladies compression garments, abdomen and legs, simply because it's a redistribution tool back into the chest. Again, I cannot go into the detail here why. There's actually a beautiful amount of evidence to suggest that this is really one disease continuum. So I exercise all of these patients. If there's some concern of shortness of breath, dizziness, or whatever that might be, we exercise them invasively. So I train to, Duke has a very long-standing tradition of doing exercise testing. Back into the 70s, we've done it upright with Higginbotham and colleagues and sort of teetered out to be more supine. Then I went to Mayo Clinic and trained there with Barry Borlaug to sort of learn his techniques. But I will tell you all that position has been very much so underestimated in the position of the exercise itself and why. Gravity turns to be out a big contributor to our physiology. This is the setup we have in our cath lab. We do both exercises back to back on the same day. Not that exercise supine is already not painful enough. I like to hurt myself and do it back to back with 2 exercises. And this was all triggered by this one case we published and that got a good amount of attention and led to subsequent investigations. This was a pastor, 7 years old. He got more shortness of breath. He couldn't get through his sermon and was getting short of breath, winded, a little bit dizziness. He didn't make a big deal out of the dizziness part. He was put on the cath lab table. His wedge went from 10 to 28 with 40 watts of exercise. Meets criteria. Anything above 25, we call it HFpEF. Mean PA went up. Arterial pressure notably was measured with a cuff, wasn't significantly going up, which was a little bit of a red flag right then and there. He gets torsemide and spironolactone, 20 milligrams torsemide, spironolactone, goes home and feels worse. He thinks we're morons because he now feels worse. We're supposed to be doctors. What are we doing? So he comes back and says, well, something's not making sense. Let me do the same test in the upright position. The only exercise we're doing supine is not the exercise I want to reproduce on a cath lab table. So it's more natural to do exercise anyways in the upright position. We just do it out of comfort and safety in the supine position. I did my upright. Here's what we found. His wedge pressure did not increase significantly. Neither did his mean PA. And his arterial pressure now measured invasively actually fell throughout the course towards the peak exam. This man had classical preload failure. What is preload failure? That is either dysautonomia, venous occlusion, or liver disease that leads to those states. And those are the ones that muddy the water. So now comes a problem. What do I call this man? Because in the supine position, he has diastolic dysfunction. In the upright position, when he walks around, he does not have HFpEF. You cannot call this man HFpEF. So I refer to this as a discordant HFpEF state, meaning supine to have diastolic dysfunction, but in a loaded condition, legs in the sky. That's a loaded artificial condition. In the upright position, when he does his grocery shopping and does his ceremony, he does not have HFpEF. He's limited by something else and high filling pressures. So we said, okay, something is not right, because that is obviously going to be a fundamental shift if we're doing the test wrong. So we did a design with 2 centers. I went to Milan, and we trained a center up in Milan to do the same thing as we do, because I wanted to have external validation. A patient in North Carolina looks very different than a patient in Minnesota or in Italy. So we did a supine exercise test. We went all the way up to 20 exercise. So they did rest, legs up, 0 watts, 20 watts. 20 watts is nothing. It's just walking on flat floor in a steady state in the mall. We gave them a break. If they qualified for HFpEF in that position with a wedge of greater than 25, that's quite a tall ask. You had to meet criteria very quickly, so there's no doubt you have HFpEF by our traditional metrics. And we gave them a break. We instrumented them to go upright, re-zeroed everything, and exercise in the upright position. But now we went to peak. We gave them the extra chance to go all the way out to peak to meet the wedge criteria of 20. We discounted the goal, not 25, but 20, because gravity gives you a 5-point discount. And we accounted for slopes and all of that stuff. We essentially made it very easy for them to meet criteria in both positions. And what we found is that half, it's now only 36 patients, but we have now 90 patients where that's exactly the same data is going to follow as a publication. Half of the population that met criteria for HFpEF supine did not meet the criteria upright. So now these were dysbionic exertion workups. The average NT-proBNP was around 300. Some had more, some had less. But it shows you that you got to be very careful labeling people with HFpEF supine. So that explains, for those that do shunting studies, splanchnic degeneration studies, we screwed ourselves in the last years too heavily relying on the bike. I love bike. It's 90% of my business. But the problem is we will overcall HFpEF, and the patients that we overcall it in are the ones that have particularly obesity. And we can talk about the contribution of obesity. I have a statement that if you have a BMI of 35, I will always make you look, whether you're 10 years old or 100 years old, with a BMI of 35, you will have HFpEF on the table. Because obesity in itself has constrictive effects. It will elevate the filling pressure above 25 with exercise, period. But in upright position where obesity is not contributing to your filling pressures, that goes away. So we have no obesity phenotype in the upright position. It never exists. You either have HFpEF through diastolic dysfunction or not. So I think there's going to be some revelation coming through. I had a hard time in the review process. A lot of rejections. Some people at Mayo might have not liked what I'm telling them because that will change how we do inclusion criteria into clinical trials and clinical practice. This is not pretty. And if that not sunk in, this is changing my practice because I have no good confidence now to tell patients that have HFpEF in a supine position unless also test them upright. We are, though, developing predictors that are allowing you to tell just with physical exam or with supine tests who will likely be going on to be concordant or discordant, because I understand that this is not doable in most cath labs in the country. Concept number 3 is that while we obsess when we talk about decongestion about the kidney, it might actually not be the kidney that we should be caring about. First of all, we might not need diuretics in half of the patients. Hopefully that concept became clear. We might not need to focus so much on the kidneys. So I pulled up, cardiorenal syndrome. We love the word cardiorenal syndrome. I asked 10 patients, people in this room, what is cardiorenal syndrome? I get like 20 answers from you all. And this is like just the last 10 years of publication of cardiorenal syndrome. Everybody's beautiful graphics, all pulled together. But my problem with cardiorenal syndrome is that we target the total body volume, but the kidneys have only access to the intravascular volume. I'll explain. The majority of volume, not blood volume, volume in the body, 70% of the total body is water, sits in interstitial space. The intravascular space in a 70 kg man is only like 3.5 to 4 liters. So the minority of water is in the intravascular space. Remember where your diuretics work? Intravascular space. The kidneys, they don't work on the extravascular space. So we are really trying to remove water out of the leg edema through an indirect pathway. So one of my favorite experiments actually was done at Mayo Clinic by Wayne Miller, because what he did is he did admission and pre-discharge BVA. So this comes back to the concept of what actually happens to your hospitals. These were severely volume overload patients. They did not take patients that was concern maybe they have no volume on board. These are true 3+ edema. He diuresed them, and what he found is that when you diurese somebody, he had in average 12 kg volume loss. That is how much they lost on a scale. But at the same time, when you measure the blood volume, they only lost 240 cc's. So they lost 240 cc's of intravascular volume, but they lost 12 kg or 12 liters on total blood volume. So clearly, your diuretics did very little to the intravascular space. By the way, that's the same space you're looking at the necks. Your intravascular space that you're looking at the neck only changed by 200 cc's. Yet the extravascular space is the one that changed the majority of the amount. So that comes back to interstitial fluid and lymph fluid as we refer to it. So lymph fluid is actually fascinating. It's one of those things we never think about lymph fluid because we can't measure. You can't study what you can't measure. It's very hard to measure interstitial volume. It's very hard to measure lymph flow. But we could produce about 8 liters of lymph flow every day. Lymph collects everywhere in the body and goes into the left. The majority of lymph fluid drains into the left chest, 3/4 of the body, and 1/4 of the body, just that chest, drains into the right side. Am I getting it right? Yes. So around 3 liters of lymph actually end up dumped into the venous system. The majority of it gets actually exudated back into the tissue and reabsorbed. So it's a big life cycle. It's very poor in protein. So it has a fraction of proteins that is in the interstitial space or intravascular space actually gets transported through the lymph fluid. It's around 3 grams or less. So it's about half of what you have in the intravascular space. And it's very, very important that lymphatic flow is majority passive, but it has muscle components. The lymph vasculature has pumps throughout the vasculature that's feeding it slowly through against gravity into the costophrenic angle. So that's the drain situation. The majority of the blood drains into the left side. 1/4 of the body drains into the right side. This thoracic duct, as we refer to, that sometimes get nixed by surgeon because it runs across the spine, that's the one that if you cut it, you might be in a lot of trouble because now you have 3 to 8 liters of fluid dumping into the thoracic cavity, which is why that's an emergency and you need to embolize it if you can. So can you measure interstitial pressure? Yes, you actually can. You can stick literally a needle, there's special needles, into the tissue in any different part of the body and measure the pressure in the organ system. So these are cardiorenal patients that were going towards dialysis, and you can see that the interstitial pressure is in a single digits, whereas the interstitial pressure in all of us is actually -2, -1, -2. We all have a slight negative pressure in our tissue because that's what allows through the oncotic pressure in the intravascular space to suck the interstitial fluid into the intravascular space. But when you're congested, or you're a nephrotic patient or cardiac patients, you actually have high interstitial pressure. Thus, you don't drain that fluid necessarily back. So now there's several modes of failure how the interstitial space, which is, I think, one of the big drivers of cardiac decompensation, leads to acute decompensated heart failure. When you have high CVP, let's say your heart just doesn't work right, you have backflow, and high CVP will actually prevent drainage out of the thoracic duct. The thoracic duct, in average, has single-digit pressures. By the time it is up here in the thoracic cavity, it has barely a couple of millimeter Hg pressure. So it has to overcome a valve that sits at the end and go into the central venous system. If the CVP is 20, it simply cannot drain. Mode failure 1. Mode failure 2 is that capillary leakiness. You might absorb some of the leakiness of the fluid, but it leaks out because of inflammation, liver disease, and all of those things. And then I'll go to the renal function here in a second. So we know that in heart failure, you have an 8-fold increase of lymphatic fluid production. Why? Because through the high CVP, you actually also produce a lot more lymph fluid. So instead of now 8 liters, you produce maybe up to 40, 50 liters of lymph fluid a day in a setting of heart failure. Most of that gets absorbed and tried to be transported up to the thoracic duct, but it can't if there's too much CVP in first place. Obviously, that does not happen overnight. So there is actually a pressure at which, and this is a sheep study, there's a pressure at which if the CVP goes into the zone of around 15 or higher, you seize any outflow, this is flow out of the thoracic duct into the CVP. Once your CVP reaches 17, 18, you simply cannot drain thoracic duct, which brings us back to some companies that try to decompress the thoracic duct system by just providing an outflow. Another interesting study published in JACC a couple years ago demonstrated that just in HFpEF patients, if you take HFpEF patients not far along their disease state, and you look at the microvasculature, not arterial and venous, but actually lymphatic, the lymphatic vasculature is actually reducing its compliance. Similarly, now we can measure compliance in vasculature, arterial and venous. You can measure the compliance of the lymphatic system by its ability to store interstitial volume. It's reduced, likely through inflammation or with other aging processes that are going on in these patients. But that might be one of the key drivers. If you cannot transport away interstitial fluid and dump it into the central vasculature, you will start accumulating. Thus, a hypothesis is that the inability to regrow lymphatic vessels, which is driven by VEGF-C and VEGF-B, and some destructive processes are actually what's driving us to develop edema in first place. So here's a hypothesis. Who has those patients that are belly swellers versus leg swellers? These are distinct people. What if I tell y'all that this is actually driven by differential distribution of lymphatic vessels and differential destruction of lymphatic vessels? Those that swell only in the belly have some issue with lymphatic drainage from the belly. It's not that they accumulate fluid here, it's that they don't drain it. We have to reverse our thinking here. Same thing is with the legs. Those leg swellers that never swell in the belly just simply are not able to drain from leg. And we know from the pediatric space, and I have no time to go into this, that you can have differential expression and derangements of lymphatic tissue in different organ systems. We know that from congenital space because they have actually done a lot of embolization stuff. And then the last point, I want to not belabor too much, but we should not discount the fact that the kidney itself, it drains more than half of its fluid through lymphatics. Some of it dumps back into the calyx and it flows off as urine or goes into the bloodstream, but about half of it actually gets drained through lymphatic tissue. So if you have high thoracic duct pressure, because it has to drain the thoracic duct out into the central venous pressure, you cannot drain the fluid. What happens? It's an encapsulated organ. It now becomes very, very stiffened and cannot drain the fluid. So actually, there have been now several, and then now you have a worsened renal function. In the interest of time, have people tried to drain the thoracic fluid directly rather than make people pee? Yes. Historic experiments published in New England Journal in the past, they drained fluid. But remember, this is pre-diuretic era. They stopped all diuretics in these patients, so they had only Lasix back then. They drained this lady 30, 40 kilograms, so this gentleman 30, 40 kilograms, and that's only through cannulating thoracic duct and dumping all the fluid into a bucket. They've done it now in 5 patients, and it published that in New England Journal back then. They didn't go anywhere because obviously very invasive. Actually, a patient died. You screw around with thoracic duct, you can get into a lot of trouble. We actually repeated an experiment with now a total of 5 patients. We went to South America. We went to actually my cath lab as well, by actually cannulating thoracic duct minimally invasively, not by opening up surgically and draining the fluid. We were very careful. We only dumped 300 to 500 cc's of fluid. But you would be surprised. The pressures in the system fell pretty quickly. Some of that's a single arm study, maybe some placebo. But some of that is, my patient actually started peeing pretty quickly. I'm wondering to some degree whether you decongest the kidney just enough to remove the capsular pressure and it starts peeing. This patient did actually pretty well for a short time. This is what it looks like when you decompress this patient. Only 300 cc's removed in 3 hours. This is what the thoracic duct pressure is. So the pressure in the thoracic duct dropped by 10, 20 points. Just right then and there within a couple hours. So little volume makes a lot of difference to that encapsulated system. That's what thoracic fluid looks like that we dump to the trash. And later I found out, hey, did we store this for more analysis? Like, no, we dumped it. So that was upsetting. Anyways, conclusion, last slide. So congestion is a complex concept. There's no two people that will agree what they have in their mind as congestion is actually translatable to the other person's mind. Pressure does not equal volume. The shirts are coming, supported by Peter. Thank you very much. The distribution of blood volume could be a key driver of intracardiac pressure elevation. There's a segment of the population, probably half, and the lines are blurred, where decompensation, elevated filling pressures in the neck, or even 1+ edema is simply driven by distribution rather than volume overloads. The splanchnic nerve is something we're actively investigating to identify those shifters. It's going to take us a little bit to identify who the shifters are. We'll get there. But we identify them. That might be a better way to prevent the shifting and decompensation rather than diuretics and our standard pressure-guided approach. And then gravity matters. You know, I hate to drop that bomb on you all because we just had that paper, except it's not even published. But we've got to be very careful. The most underutilized test in human medicine is orthostatic testing. Just stand the patient up. If they have orthostatic blood pressure drops, you screwed. This has nothing to do with cardiovascular conditions. This is vascular, maybe at best. They have pooling issues. But the pulse pressure is a much more sensitive tool. If they stand up and the pulse pressure narrows, they are not able to maintain stroke volume. Pulse pressure is a stroke volume surrogate. If they stand up and the PP narrows, gets smaller, you're screwed. Because they are not able to maintain cardiac output. They're either very advanced heart failure or much more likely preload failure. In post-COVID, till proven otherwise, they have some dysautonomia or liver disease that's contributing to this state. And you know, other decongestion, I didn't present you all the industry targets that have been developed to focus on interstitial space, but there is attempts to decongest interstitium directly, rather keep hammering the kidneys, keep hammering the intravascular space. If the majority sits in interstitial space, maybe just drain it straight out of there. Thank you very much.
Thank you. That was a tour de force. It was perfect. Very well done. I have one quick question. You know, in HFpEF, for example, and with the MEMS data, I think those of us that take care of MEMS patients see this, where you have someone that has high pressures, you push diuretics, they don't get better, they get renal failure. It's clear that it's not working. Yet there's also been some data suggesting that pushing vasodilators in HFpEF patients is not effective. What are you doing clinically with these patients that have high pressures where you don't think it's volume, yet the pressure treatments aren't, maybe, at least in my experience, haven't been very effective?
Correct, and usually they're optimized by the time that you can get the cardiac MEMS. So it's really hard to push GMT at the time. But so we actually withdraw diuretics in those patients where we have evidence of euvolemia. So we actually just take away potential offenders of RAS activation. But in all reality, we just become more conscious of diuretic use and then try to just push GMT more. Not for the vasodilator properties per se, but the neuromonal properties. Acknowledging that diuretics is not going to change the field, or accepting the fact this patient might be living at a rate of 20, no matter what we do.
Right.
Which there's plenty of those too.
And then another question I have is, and I was glad to see you talk a little bit about the role of the autonomic nervous system, because I think it's a big deal, and we know so little about it, and clinically we don't have much we can do about it. Are there ways or parameters that you use clinically beyond the things you've described in terms of orthostatic failure and so forth, where you would say this is someone that seems to have autonomic failure or heart rate variability, or there are other tests or other things you're using to assess this, to be able to, as they often say, diagnose and adios, because we don't have a way to treat autonomic failure. I'm curious if you have any comments.
I mean, there's a standard battery of testing, but orthostatics, the properly done, it's 10 minutes in each body position. You have them lie flat for 5 minutes and sitting for 10, standing for 10. That's the definition, because you got to wait a little bit for them to declare themselves. And then tilt table testing, which I don't do very often, because this really doesn't represent reality. Who stands strapped 40 minutes to a table? It's just, this is not translatable to what patients experiences. And then, we do a lot of inflammatory testing and rheumatological testing. If you suspect somebody has dysautonomia and they haven't been, sick with COVID, dramatically sick in the last few years, and you have a positive ANA, some other rheumatological markers popping up, this is becoming a very strong case for this is actually dysautonomia. And it's very important. The signs and symptoms a 30, 40, 50-year-old patient presents with dysautonomia, shortness of breath, fatigue. And if you don't listen to the signs and symptoms, it might sound very much so like heart failure. And with COVID being around the block, we have patients that have heart failure and dysautonomia now, teasing those two things apart, there might be 60 and 70 is very tricky because the echo looks like HFpEF, but that's not what's limiting the symptoms.
Mhm.
So I think, to be honest, for us, it's the upright exercise test, detailed orthostatics, and what you do about it is actually often peel back on heart failure-based therapies and diuretics because they just need more volume, compression, salt loading. But the toughest patient to handle is one that truly has heart failure and truly has dysautonomia. These are disasters because you give them too much salt, they become volume overloaded. You give them diuretics, they get more dizzy.
Yeah, we'll have to send those to Duke.
Yeah.
Any other questions? Yes, Job.
Brilliant talk, Marat, and thanks for challenging us in so many concepts. I have to rewatch the video here to get it right. I wanted to challenge you on the concept of the pressure volume, because could pressure influence volume distribution? And what I'm getting into is intra-abdominal pressure. So you get these patients that are morbidly obese, huge belly, they have cardiorenal syndrome. They don't. And there is some work by Wilson Tang that shows that might be also a contributor to volume distribution. And the second comment I would like to talk about is in those, I love that supine and upright bicycle stress test that you described. Is there anything on the hearts that is different about these two patients groups?
So first one, so I absolutely right. When we say volume distribution, that's why I made the comment on obesity itself. There's a mechanical distribution of blood volume. You can just push, which is why we do the hepatogyral reflex. That's the same concept. Or you're obese, or you have actually ascites. On Friday, I was rounding for a day or to cover. That patient had 10 liters of fluid in the belly, and that was actually not properly recognized because we don't address our patients these days. And the next days were here, and it's like, oh, should we give the patient diuretics? Like, we just take the fluid out, it probably will drop by half in itself. So mechanical and vasoconstriction can both lead to the same. Of course, remove the mechanical issues if you can, but often it's obesity in our society. To the pressure, to the intercardiac changes. So what comes out in that paper will shows that the people that were more likely concordant, true HFpEF in both body positions, no matter how you stress them, if they had larger LAs, if they have AFib, they were 100% actually having concordant disease. And if they had higher filling pressures. What does that mean? Well, if you had long-standing, stretched out structural disease of the heart, you more likely will then also have true cardiac disease. That also then suggests that patients that have discord, meaning supine have disease, but upright that don't have HFpEF criteria, is that they might be just early in the disease course. And then in a loaded condition, we unmask them. In the unloaded condition, we don't. They don't have the disease. And I think that's probably that's somehow that's what we struggle with the reviewers is that we didn't say that they don't have HFpEF. It's just we're saying they don't meet HFpEF criteria. But I think it's probably both of those things: early in the disease course, or they don't have disease in the first place. But yeah, if you have advanced structural disease, you will more likely have HFpEF. But remember also, these are dyspnea of unknown origin. If you had LVH 3 centimeters, LA of 7 centimeters, we didn't put you on a table because these are clinical tests. There was no doubt you have heart failure. So we had patients where there was either a concern or no insight into what was going on in the first place. Yes.
Paul?
Amazing talk. Lots to unpack there. And I'm just trying to keep up with you. But tell us, so the V-wave data were really controversial. With the subgroup that was entirely positive, subgroup that was entirely negative. Do your concepts or your challenging of concepts explain some of those discrepant findings? Can you put that into context for us? Because obviously atro shunts are like, everybody's looking for what's next.
So I love that's a very good comment.
Could you ask us or help us with that?
So actually changed my practice. I'm top enrolled in Allevion in the US, which is one of the shunts that we're doing. So I obviously love this technology and an approach. And as I started developing this concept, my enrollment started slowly leveling off a little bit because now I went to everybody being supine upper exercise. What I didn't disclose to you all is that when we measure LA to RA pressure gradient, remember, you don't put a shunt into somebody if there's no gradient. When you exercise people supine in the concordant group, they're the same 5+ gradient supine, rest and exercise, and upright rest and exercise. If you have real heart failure, you're always going to shunt. Guess what happened to the discordant patients? They had an average gradient of 2 to 3 when they went upright. If they don't have HFpEF upright, they're also not going to shunt because they have no pressures. That's 99% of the day you spend is going to be in the upright position during daytime hours, right? It's not going to be lying supine. So the problem is that I'm 100% sure that some of the HFpEF neutrality data. That trial and other trials will simply explain we didn't have the right patient on the table. So now there's some disclaimer to this. One of the predictors of concordance was if the antiproton is greater than 300, we had those patients in sample. Of course, if the inclusion criteria is to mandate LA size of this size and 5 hospitalizations and an antiproton high, you likely have concordant disease. So I think some of the of my concerns of they got the wrong patients just got erased by the fact that they went for sicker patients. So I think I'm not as worried about this, but there's, like with the amyloid story, where you sneak in the wrong patients with the amyloid into HFpEF trials, you're sneaking in some discordant HFpEF patients into trials for sure. And in the Splanchnic trial, our trial, they went so easy on inclusion criteria, we definitely snuck in many patients that had no business being in the trial.
So you think in the V-wave data where it was negative or harmful in the HFpEFs, a lot of those were actually not HFpEFs?
I would have to look at the breakdown of the data. They don't show it to us, but I can tell you the average NT-proBNP in the HFpEF group is 1,600. So there's a lot of sick puppies. I think they actually got it wrong the other way around. They got way too sick patients. I do not have clinic patients that have NT-proBNP of 1,600 in average in my HFpEF patients. I don't. So I have no idea who they included there. I know for a fact that went pretty shortly after hospitalization, the majority of recent hospitalization in the last 6 months. So I think they got it actually the other way around. They actually two sick patients.
And I want to ask a follow-up on that because my understanding is that the Alleviant trial just recently changed their criteria where if you have the pressure discordance, and by that I mean high wedge pressure, low right atrial pressure, and have the appropriate hemodynamics, but you have a low BNP, that those could be enrolled. Because we recently screened a patient like that who screen failed, but then they changed it so that the low BNP patients could get into that trial. Do you think that's a mistake?
I was, what is it? There's like this movie where there's always one, the movie World War Z. It's like one of my favorite movies with the zombies. And it's like, when I go to Israel and one of the days, like we have this 12th man that always says the discordant view. Like I'm going to disagree with everybody else. I was the one on the panel because I'm responsible for this. I said I don't agree with those changes. Because my concern was we're going to make it way too easy to get in the trial now. We're going to have a lot of muddy water. They didn't declare themselves to be true heart failure.
You may be letting people in that have what you describe as the
no
discordant. They're either early HFpEF or maybe don't have it. Interesting.
Right. So got to be conscious about this when you do it. I truly, honestly mean it. Just do orthostatics on your patients. It's a little bit of a pain, but let your nurses check in. You would be surprised what stuff you get when you do orthostatics on patients. There's a lot of orthostasis you will uncover. And then you start that conversation. Why are you actually getting dizzy? The second is just ask patients if they're dizzy. We don't ask the dizziness question. Many patients will be not just with bending over, but actually dizzy with walking. If they at any time point say they're dizzy, big red flag that this is not classical HFpEF or heart failure in general. Unless it's advanced disease, they're allowed to have dizziness if there's no stroke volume. But that's advanced disease, you'll be able to tell it easily. There's no confounding with it. But the early, that's where it's a red flag if they're dizzy.
John, any questions online? Otherwise, we're going to have to close here.
We do have a couple questions online. Dr. Fudim, thank you so much for your time this morning. Fantastic presentation. First question is from Dr. Renowitz. The question is, how do you look at pro-BNP, pressure or volume? She goes on to say, what if PAD is high, great worsening work, diuretics, BNP is high?
So actually, I took a slide away. BNP was correlated with blood volume analysis and had the same lack of concordance as R square of 0. So there's no correlation between BNP and actual intravascular volume. BNP is more of a circuit of pressure than volume. So the correlation with pressure is going to be linear, but the one with volume is neutral. So I mean, I use it as a pressure signal rather than a volume signal.
Thank you for that. The last question and comment here is from Stephen Goldsmith, and he says, Steve Goldsmith here, spectacular talk, and thanks for coming to give it. I agree completely that the pathophysiology of congestion is much more complex than we normally appreciate. We do need to think more carefully about important details of pressure and volume to improve treatment in heart failure. I hope some of the newer approaches bear fruit. In the meantime, though, we should remember that the main intervention in Champion was in fact to increase diuretics, to lower the PAP, and that did significantly reduce admissions. So in the absence of more sophisticated assessment, it is still a good place to start and to be prepared to reverse course if the patient does not improve or gets worse, i.e. renal function tanks.
So we're getting some rebuttals here. I like it. I like pushback. So it's completely true. First of all, I would say Champion wasn't really that positive. And if you have somebody, if you shove a $25,000 device in somebody and you only improve heart failure hospitalization at 12 months by 28%, we probably could have done better. Having said that, 60% were diuretic changes, 40% were non-diuretic changes. So those could have contributed to those. You can't argue against that. But you're completely right. I mean, in the absence of us knowing what the physiology is, we're not gonna probably do too much harm playing around with diuretics, particularly if you scale back, if there's no benefit from that. We have another paper I didn't show you all, is that when you go longitudinally and you look at those pressure volume discordance patients, we actually now follow them up with serial BVAs and serial pressure measurements. And the relationship of pressure and volume today was X, concordant or discordant, but in follow-up that changed in about 50% of cases. So that is the tricky thing about cardiology, is that just because today you are compliant or non-compliant does not mean that 6 months later you're compliant or non-compliant the same way. And that speaks to that you can try diuretics, it's gonna probably work longitudinally, as one of our armamentarium, but it's not the only solution. But again, what I give you a grain of salt is the relation of pressure and volume is fluid. It's not constant, which totally makes sense because your sympathetic tone changes every few seconds. I'll relax you in a second and my sympathetic tone will go down.
When you say the relationship is fluid, it confuses me. You almost should say dynamic.
Dynamic.
It's
Yes.
Otherwise, the relationship between pressure and volume is
Yes,
fluid.
dynamic.
Wait a minute. Yes. Anyway, thank you. Really thought-provoking talk. Tremendous.
Thank you.